goal of trying to understand medicine as a kind of performance. And whether by looking at how people do their jobs in medicine, you begin to have ideas and lessons for how performance really works at something that's high risk, that's something that's difficult, and in a job that's very human. It pushes us in ways that we aren't necessarily pushed in other walks of life. The idea of what it means to think of medicine as a performance has come to me over and over again through experiences in medicine. And I wanted to read a little bit from the beginning of a case that brought home exactly what the difference is between a kind of ordinary, competent performance and great performance. Several years ago, in my final year of medical school, I took care of a patient who has stuck in my mind. I was on an internal medicine rotation, my last rotation before graduating. The senior resident had assigned me primary responsibility for 3 or 4 patients. One was a wrinkled, 70-something-year-old Portuguese woman who had been admitted because, I'll have to use the technical term here, she didn't feel too good. Her body ached, she was tired all the time, she had a cough, she had no fever, her pulse and blood pressure were fine, but some laboratory tests revealed her white blood cell count was abnormally high. A chest x-ray showed a possible pneumonia. Maybe it was, maybe it wasn't. So her internist admitted her to the hospital, and now she was under my care. I took sputum and blood cultures, and following the internist's instructions, started her on an antibiotic for this possible pneumonia. I went to see her twice each day for the next several days. I checked her vital signs, listened to her lungs, looked up her lab results. Each day, she stayed more or less the same. She had a cough, she had no fever, she just didn't feel good. We'd give her antibiotics and wait her out, I figured, and she'd be fine. One morning on 7 o'clock rounds, she complained of insomnia and having sweats overnight. We checked the vital sheets. She still had no fever. Her blood pressure was normal. Her heart rate was running maybe slightly faster than before, but that was all. Keep a close eye on her, the senior resident told me. Of course, I said, though nothing we'd seen seemed remarkably different from previous mornings. I made a silent plan to see her at midday, around lunchtime, several hours before I'd usually see her on my afternoon rounds. The senior resident, however, went back to check on her himself twice that morning. It is this little act that I've often thought about since. It was a small thing, a tiny act of conscientiousness. He had seen something about her that worried him. He had also taken the measure of me on morning rounds, and what he saw was a 4th-year student with a residency spot already lined up in general surgery on his last rotation of medical school. Did he trust me? No, he did not. So he checked on her himself. That was no 2-second matter. She was up on the 14th floor of the hospital. Our morning teaching conferences, the cafeteria, all the other places we had to be that day were on the bottom 2 floors. The elevators are notoriously slow. The senior resident was supposed to run one of those teaching conferences. He could have waited for a nurse to let him know if a problem actually arose, as most doctors would. He could have told a junior resident to see the patient, but he didn't. He made himself go up. The first time he did, he found she had a fever of 102 degrees and needed the oxygen flow through her nasal prongs increased. The second time, he found her blood pressure had dropped and the nurse had switched her oxygen to a face mask, and he transferred her to the intensive care unit. By the time I had a clue about what was going on, he already had her under treatment with new antibiotics, intravenous fluids, medications to support her blood pressure for what was developing into septic shock from a resistant fulminant pneumonia. Because he checked on her, she survived. Indeed, because he did, her course was beautiful. She never needed to be put on a ventilator. The fever stopped in 24 hours, and she got home in 3 days. You begin to understand when you look at someone like that resident why this question of what it takes to be good at something is particularly interesting in medicine, because it's a place where failure is easy. Failure is effortless. And what's striking about the people who do a better job than others is that they're not geniuses. Jamie's not smarter. That's the name of that resident. His name is Jamie Winshaw. And Jamie is not smarter than other people. What he had was something more than competence. Competence is your ability to know how to do things in general. So he knew how to diagnose a pneumonia. He knew the textbook answers about how to treat a pneumonia, but he knew something more than just that. He knew what it was to treat a pneumonia and find it in that particular person, in that particular place, in that particular moment, with the resources and the strengths and weaknesses of the people that he had around him. We're used to looking to athletes to understand performance. And there's a lot they have to teach us about hard work and perseverance and the importance of practice. But what I'm trying to get people to think about as they turn to something like medicine is that there are dimensions to be found in what we do as human beings in medicine that are not to be found on a playing field. And those dimensions might teach us about other things we do. One dimension, for example, is that lives are on the line. That because we are taking responsibility for other people, the enterprise becomes a moral enterprise. The second thing is that medicine is dauntingly ambitious. It is an effort to bring the science and technology that we have available, that's been discovered, and make it available on a person-by-person basis for everybody in a country, if not around the world. Somehow for 300 million people to get that know-how to you. The third dimension is that this is not an individual enterprise. It's not just whether I, as a surgeon, can sew really well, can make a good diagnosis. The ability to deliver requires actually hundreds of people for the care sometimes of a single person. So all the nurses coming in on each shift, the cafeteria worker whose responsibility is to deliver the right tray at lunchtime, the one without the concentrated sugars for the diabetic patient, the one without too much protein for the kidney patient. You have everybody, the engineer who has to make sure the oxygen works, the IT person making sure the computers we now depend on are actually up and running, all the way down to the doctor. So it's hundreds of people somehow who have to make this go well.